Now, we have addressed major depressive disorder in our first video, and for the second video this week, we're going to shift gears and focus on our second group of mood disorders, being bipolar disorder, which is treated using a group of mood stabilizing agents. Now, like some of the other conditions we have discussed in this block, the exact pathophys that leads to bipolar disorder is unclear, but there are a number of theories out there, and many revolve around neurotransmitter imbalances, as you might expect with conditions that are defined by manic, hypomanic, depressive, or mixed episodes. Now, we will not focus this video on the differences between bipolar 1 and 2 and cyclothymic disorder, but instead we will focus on these neurotransmitter imbalance theories that may explain these conditions and the mood stabilizers that may help. The first theories we will discuss will be the monoamine hypotheses. So first, serotonin plays a key role in stabilizing neurotransmitter levels like dopamine and norepinephrine. So the thought is that serotonin is low in both depression and mania, and that the level of dopamine and norepinephrine at any time dictates whether that patient is experiencing a depressive or manic episode. So high dopamine and norepinephrine lead to hyperactivity, psychosis, and mania, whereas low levels of these lead to depression. Supporting this theory is the fact that agents that reduce catecholamines can reduce mania. So now let's touch on the GABA versus glutamate theory. So if there is low GABA and or high glutamate, the thought is that this can lead to high norepinephrine and dopamine levels downstream and that mania. And if GABA can be increased and glutamate lowered, then this can treat mania. So these are the two primary theories that we will focus on with our therapeutics. And then just keep in mind that downstream, these neurotransmitters at either appropriate or inappropriate levels are released to act upon their respective receptors and signal through secondary messengers to lead to either mania, hypomania, depression, etc. Now, if these neurotransmitter levels can be normalized, so if we can decrease glutamate, we can decrease norepinephrine, decrease dopamine, and increase serotonin and GABA, mood can be stabilized and maintained to avoid any manic, hypomanic, depressive, or mixed episodes. And as I alluded to before, we can use mood stabilizers to do this. And this will be a very quick video because we have already talked about two groups of mood stabilizers. And we do not really fully understand their mood stabilizing mechanism of action, just like the pathophys behind bipolar disorder. So we will just move forward assuming that their mood stabilizing effects are also due to their mechanism of actions that we've already discussed before for other indications. So the first group of agents we're going to talk about are our mood stabilizing anti-epileptic drugs. And for example, this includes valproic acid and carbamazepine, as well as others like lamotrigine, all of which have that sodium blocking potential, which will prevent the release of those elevated neurotransmitters that are promoting mania or hypomanic episodes. So some of these anti-epileptic drugs do have activity at other targets involved in glutamate and GABA signaling, which may lend to their mood stabilizing activity. So we've already went over their mechanism of actions and ADRs of these agents, so we do not need to rehash that. Next up are going to be our mood stabilizing antipsychotics. And these are primarily going to be our atypical antipsychotics, which will block those D2 receptors, counteracting that high dopamine level, also hitting those presynaptic serotonin receptors to regulate the release of other neurotransmitters, ideally normalizing neurotransmitter imbalances. But keep in mind that the full mechanism of action behind these as mood stabilizers is unclear. And again, we've already covered these agents in depth in other videos, so we will just move on to our last mood stabilizer. Last agent is lithium, which is effective as monotherapy or in combination for acute manic episodes and maintenance therapy. And its mechanism of action as a mood stabilizer is also unclear, but for now, the leading theory is that it alters secondary messenger levels by depleting inositol, so that phospholipase C can't make IP3 to mobilize calcium and propagate signals from those imbalanced neurotransmitter levels. So now, while lithium is an effective option, we have a lot of pharmacologic considerations to keep in mind. The most important being that lithium is a narrow therapeutic window drug with a narrow window of 0.8 to 1.2 milliequivalents per liter. So because it is a monovalent cation, like sodium, it will be rapidly absorbed, widely distributed, not protein bound, not metabolized, and excreted renally unchanged. So renal function will have to be sufficient and monitored. Also, many medications that alter renal function, like our ACEs, inhibitors, our ARBs, our diuretics, and our NSAIDs, or anything that promotes sweating, diarrhea, or dehydration in other ways increases the risk of lithium toxicity. And these are important considerations to be aware of because toxicity can appear very close to the therapeutic range at greater than 1.5 milliequivalents per liter, with more extreme toxic presentations occurring at greater than 2. So lots of lithium level monitoring, and this is listed as a black box warning. Now, for other adverse drug reactions to be aware of beyond lithium toxicity, which we'll get into more in just a second, there can be electrolyte imbalances from lithium competing with other cations. We can have altered cardiovascular function, and this can also lead to polyuria and polydipsia. Lithium can also alter thyroid function and will require testing at baseline and during treatment because lithium actually gets concentrated within the thyroid and inhibits the release of thyroid hormones. So there can also be CNS related side effects as well, like ataxia, tremor, and confusion. And then long-term, lithium can actually lead to nephrotoxicity, which is not ideal with an agent that is purely renally cleared. Now, there are a slew of other ADRs as well, but these are some of the big ones. And then we should talk about lithium toxicity just briefly. So if for whatever reason lithium toxicity does present, it can lead to seizures, cardiac dysrhythmias, permanent neurologic impairment, and nephrotoxicity, as well as impaired consciousness, and will need to be treated with supportive measures like fluid and dialysis. So it's very important patients understand the benefits, but also the risks of lithium treatment and how you and the patient can work together to prevent lithium toxicity and set realistic expectations. Because again, adherence to treatment regimen, regardless of the agent chosen, is key to set the patient up for success. So moving to the next slide. So I know this was a brief video, but does bring together a number of treatment options in a new context and introduce a very important agent used for the treatment of bipolar disorder. So lithium provides an opportunity to revisit some of the key principles of pharmacology and how an understanding of these can be translated to lithium treatment to better counsel your patients and set realistic expectations for lithium treatment and measures to take to avoid lithium toxicity. And then lastly, take this video and the depression video and your research of mood disorders and put them together. And then I would encourage you to take a minute and just consider the risk of misdiagnosis and how treatment with an antidepressant in someone with bipolar disorder may affect the patient.